talk about the Fuller Stocktake Report. This was a report that was written by Claire Fuller for NHS England in 2022, which set out a new vision for integrated primary care, which was based on developing streamlined access to urgent care for those that need it, more personalised care from multidisciplinary teams for those with complex needs, and then a more proactive approach to prevention at a greater scale. So we've asked Linda and Holly to come here and talk to us about how that's working in Worcestershire. So over to you, Linda. Thank you very much for coming.
Thank you, everyone, for inviting us here today. In some ways, it feels like a lifetime ago since Dr. Claire Fuller, who is now the Medical Director for Primary Care for NHSE, was commissioned by Amanda Pritchard, who is in charge of the NHS in England, to look into the state of general practice, but through the lens of how the model of care in general could change to best impact on the health of the population. So the document was published in May 2022. And if we can move on to the next slide, please, Holly. What I intend to do is a bit of a double act today. I'm going to talk in very general, broad terms around aims, strategies, linkages as well, which is really important. And combined, what are they all seeking to do? I'll then hand over to Holly, who will talk about the very practical steps that have been taken in Worcestershire specifically to implement that integrated care model for patients. And then I'll come back to the final slide before opening up for any questions. So that's the format today. So as you can see from this slide, whilst NHS England were very clear in January of this year that the NHS had to focus on only 3 things, and they were urgent and emergency care. They were on elective care because of the horrific waiting lists we have currently. And the third mantra and must do for the whole of the NHS was the delivery plan for recovery of access in general practice. There are more strategies on that slide than the 3 nationals. So in addition, we have a frailty strategy, really important in Worcestershire and Herefordshire because of our demography. We have the health and well-being strategy, which reflects integrated partnership working with the local authority in addition, as well as prevention. So that gives you a flavour of strategy upon strategy. Next slide, please, Holly. What the linkages are, though, are, and there are several, are quite clear. And it's the first time in my career in the NHS that I've heard the various NHS leads for urgent care, for elective care, and for primary care wrap around what Claire Fuller said in her stocktake. And what they all say publicly now is we can't continue to work in the way that we always have. The pressures and challenges are overwhelming for all providers, be they primary care, acute, community, local authority, etc. So doing what we've always done isn't going to work anymore. And the group that are affected more than any other group by doing the same thing in the same old way are the patients. Come back to the waiting list example. So the Fuller Stocktake referenced how important continuity of care is and the role that general practice has in ensuring that for those patients who most need continuity of care, they are the go-to place. It also acknowledged the reducing numbers of GPs and therefore how important it is that they are almost ring-fenced to look after frail patients, those who are most vulnerable, long-term conditions, etc. It also reflected on the discontent of patients, the discontent of the profession, and that improving experience of access is absolutely critical as far as the reputation of the NHS is concerned. It also recognised, however, that such a mammoth change can't be done overnight. This is a huge management of change transformation piece. If you look at and read the delivery plan for the recovery of access to primary care, and our system plan went to the board 15th of November, and we had separate engagement events with Healthwatch, very similar messages and themes. Patients are fed up. The profession is fed up. We need a different approach. We need that dynamic, innovative streak that most GPs possess to be reflected across the whole system and delivery in each of our GP practices. But it also is very clear, and within the plan, that general practice can't do this on its own. And that's why there are 4 pillars within the plan which seek to take the pressure off general practice to do the things that general practice is funded to do and meant to do. So reduce bureaucracy, the workload shifting from secondary care, which isn't appropriate for general practice to pick up. That patients need to be empowered to look after their own health, and that there are 7 services identified in the plan that patients should be allowed to automatically self-refer to. They shouldn't have to go to their GP to be referred, because that delays the care for patients. So that's just a flavour of what the plan has said. And as I mentioned, it's been to the board. We had a separate engagement with Healthwatch. Next slide, please, Holly. So that recovery plan very clearly states by NHS England that the Fuller Stocktake and the vision, and the chair did a brilliant job of reminding us all of what that vision is. It has 3 simple aims. We have to build integrated neighbourhood teams. Who are integrated neighbourhood teams? Well, they're wrapped around primary care networks, but they include the acute trust. They include district nurses, occupational therapists, etc. They absolutely include social services. And the voluntary sector is absolutely imperative to the delivery in a different way of many of these services. So you build integrated neighbourhood teams, and then what you do? Well, the teams have to achieve 3 essential deliverables: improved access to urgent care, improved continuity, which I've spoken about, but more proactive, personalised care within how that is delivered to people with complex needs. And as importantly, reduce health inequalities, more ambitious approach to prevention. General practice has over 1 million contacts every day. So how they access general practice and making sure they access general practice after care navigation to the most appropriate place in the system is really important. So the National Recovery Plan says, yes, absolutely, Fuller is still the way we do things differently. But first and foremost, system, you have to deliver this recovery plan for recovering access, because until unnecessary workload is taken off general practice, they're never going to be able to play the full role in the Fuller Stocktake that they're meant to. In saying that, as we come to the slides which Holly will present, you will see that we have made inroads to some of these areas with more to do. Next slide, please, Holly. So the Fuller Stocktake framework had 15 actions, which I'm sure you're aware of. Only 7 of the 15 sit with ICSs. The others sit with the government, they sit with NHS England, and they sit with the Department of Health and Social Care. But really important, because there you see issues like funding, changes to contracts, etc. So these are the 7 that we're responsible for. I'll just touch on some because Holly will go into the detail. We have got a primary care forum at system level. We call that our General Practice Transformation and Sustainability Forum. That will very quickly become a primary and community programme board to ensure that that integration at neighbourhood level is happening. Moving on to the next slide, please, Holly. We were asked then in February of this year by NHS England to undertake a stock take. So against those actions, against the framework, where are you? What have you done? We did this at place. So Worcestershire Place contributed to the completion of this stock take. It was disappointing, going to be absolutely honest, that we only had 7 days to complete it. 7 days were the half term in England, but we did our best to co-produce and involve all providers in assessing where we think we are in Worcestershire and Herefordshire. As you can see, we recognise we weren't starting from scratch. We've got 100% delivery by PCNs. Some systems still don't have PCNs covering all their neighbourhoods. We've got neighbourhood teams, but we were absolutely clear. Are they fulfilling the vision and ambition in the Fuller Stocktake? There were only 3 statements we thought we could agree with. 5 that we disagreed with. And it's going to be really important moving forward that we repeat this locally, probably on a more frequent basis than annually. I'm now going to hand over to Holly, who will talk about the practical actions that have been taken in the 18 months that the Fuller Stocktake has been in place. Thank you.
Thanks, Linda. My name's Holly Hastings. I'm Director of Strategy and Partnerships, working with the 10 primary care networks in Worcestershire. And as Linda has mentioned in the earlier slides, we have been working for the past year or so on organising ourselves across general practice, but also working in partnership with partners across the county to align Worcestershire's response to the Fuller Stocktake. So as Linda's referred to, the policy document talks about 3 pillars, and what we've done here is created a local model as to how we can work together to deliver the 3 pillars of the Fuller Stocktake. We have engaged on this approach, starting through the Worcestershire Executive Committee, and we've had a number of workshops across the county over the past year, which has enabled us to develop this local response, and it's jointly owned by those who have been involved in developing it. From a general practice perspective, we have started to organise ourselves to have working groups to look at integrated urgent care, proactive complex care and prevention. And those of you who are involved in district collaboratives will know some of the work that we've been doing there is linked to the prevention pillar. We've been doing some work, and Linda mentioned the greater role that the Trust have in working with us in integrated neighbourhood teams. So we've been doing some work with colleagues, initially with the Health and Care Trust, looking at our collective resources and how we're currently working together. There's a lot more to be done in terms of where do we want to be and how we're going to get there, but we have started some early work to organise ourselves to enable this work to happen. And from an integrated urgent care perspective, a lot of the focus has been on winter and responding to winter over the past couple of years, but that's enabled us to have some learning around how we can better support patients, as Linda said, from a primary care access perspective. There's obviously also various system enablers around workforce, estates, and our approach to population health management that we are working together across Worcestershire on. Again, as Linda's referred to, via all of those strategies that we have across the county. And we're also looking at how we can bring care closer to home, and I will touch on some opportunities that partners have had over recent years where we are working more collaboratively and putting care and resources into the right setting. This slide shows you how we have started to organise ourselves at neighbourhood level. So Linda mentioned we do have neighbourhood teams already. We've had them for a number of years, working with the Health and Care Trust and general practice. We have the primary care networks, which are groups of GP practices. And more recently, over the past 18 months, myself and a number of colleagues have been working across the county to set up the district collaboratives, which have a greater focus and control over prevention and really going upstream with their communities. We have got work to be done around how we align our other partners. So we've got them here on it's almost a working and evolving model, but we know that there are social work teams aligned to geographies, and we need to work in a more integrated way as one team of teams. The same with the community mental health neighbourhood teams. And then we also need to look at the smaller services that are provided from an acute perspective. And also sort of underpinning all of that and working around and with us is the Voluntary and Community Sector Alliance. And that's been really helpful, having Esther and colleagues to help us navigate how we can best work with partners to support this model of care. Also, from a prevention perspective, we have really done some great work with the district collaboratives. We had a showcase event earlier this year, I think it was in February, and we were joined by colleagues from New Local who did a talk on focus on prevention and also their community paradigm. And I think that's hopefully what we're aiming for with from the district collaboratives, supporting and enhancing our assets, preventing illness, supporting a more collaboration and shared community. And I think we've definitely seen that with some of the examples and stories and narratives we hear from across partners. I know the Westlands video has been at various public boards, but we also have other examples, particularly in Redditch and in Bromsgrove, where we're working with a variety of partners and communities to support our partners. We were also asked as part of this presentation to identify opportunities for the voluntary sector. So I've just done a couple of slides summarising the work that we've done so far, and we were grateful for Esther, Jonathan and Pete and others supporting the workshop we had in June. And I'm just going to do I've just got a short summary of what we've done so far working with the sector. There is a greater representation at place-based meetings for the voluntary sector. We have done various workshops, which I've mentioned in my earlier slides, but the Voluntary Sector Alliance representatives have been at workshops either across the county or specific workshops for the sector. We have really great involvement, representation, engagement, district collaboratives and the Being Well Strategic Group. And we also have the Strategic Worcestershire Executive Committee, where the voluntary sector and Healthwatch actually are represented and involved. More recently, we had a task and finish group on the 21st of November, where we've been really looking at how we go further and faster with Fuller. And we've got some recommendations and next steps on slides in a minute to give you some insight into that. From a general practice and primary care network perspective, the impact on working with the voluntary sector has been much more involved and collaborative over recent years. There's obviously lots of opportunities for the voluntary sector and the voluntary and community sector to get involved with wellbeing roles. That's funded from the current 5-year primary care network contract. There's been a varying number of mental health projects that have been delivered in collaboration with primary care networks. And the Being Well project has also benefited from the involvement of the sector, and there's various initiatives happening with local roles across the district. And we've definitely seen a improved and closer working relationships with general practice. Of the 9.5 years I've been working in Worcestershire, I can definitely see how we're working more collaboratively together. And as a Worcestershire resident and a Worcestershire patient, I'm really pleased to see that from my perspective, and I know other people are as well. So what do we hear so far from the sector? We had the event in June, as I said, and we asked for feedback on how we think the sector's working currently and what is working well. And there's a summary there from the Mentimeter feedback that we had at the event. And I think Peter's going to talk about the subsequent work that has happened in his presentation. And then in terms of next steps, as I mentioned, we had a workshop in November, and the recommendations are going to the Worcestershire Executive Committee next week. And we hope that we'll get support there from the committee to enable us to bring Fuller to life across all of our meetings and groups that we have across Worcestershire. We hope that we can continue working with primary care networks and district collaboratives with the sector and other partners. I think we've done a great job over recent years, and really make sure that we can thrive those relationships. And also it's great to see the voluntary sector continuing to develop, and I know Pete's going to talk a bit more about that. So that's it from my perspective. I think I'm just going to go on to Linda now to...
Thank you. Final slide. So I want to go back to the very beginning in summary, just to highlight that in the midst of so many competing strategies, it would be all too easy to look at Fuller Stocktake, the report, the vision, and to think of it as a, oh yeah, that'll be a nice to do when we've got time. Let's just focus on all of these other strategies. And there's a huge risk to all of us, I think, that might happen because we're also overwhelmed. I hope, though, that you'll have gotten a flavour from just some of the work that's going on in Worcestershire, that despite that, we are really owning it and driving it at every opportunity we can, because that model of care is what will make a real difference to patients moving forward. And as a real example of how we're trying to link that new model of care to these numerous strategies, this is how we intend to implement our frailty strategy, i.e. through the lens of Fuller. So around each PCN in Worcestershire and Herefordshire, there will be a named integrated neighbourhood team. Now, those team members will very much be focusing on anyone who is identified as severe frail, moderately frail, mildly frail. And as a result of that identification, certain processes will be put in place and wrapped around that patient. And that team will include the social prescribers, a frailty care coordinator, we're thinking of having based in each PCN, to make sure that that person is receiving person-centred care, that they are aware of their appointments, that the team is reviewing them through a multidisciplinary team meeting on a regular basis, that there is a social worker attached, that Age UK, voluntary sector, are also aware of those patients, as are members of the district collaborative, so that, take the community champions in Redditch, that they are aware that Mrs. Jones, for example, is becoming more frail, more vulnerable. Is she accessing the support that's available? Is she accessing the support that's available to keep her house warm, etc., etc.? Because navigating all of these systems and support offers is a nightmare. You need somebody to guide your hand to understand the NHS. I still struggle with the NHS. And if you have dementia and you're living on your own, it's even more nightmarish. So that's how we're approaching implementation of the frailty strategy. It includes the geriatricians, consultants from the acute, etc., with other services mapped in. And if you ever have time, to listen and watch this YouTube video that I've added of the work that they're doing in Northamptonshire, where you'll get to hear from the voluntary sector, you'll get to hear from Age UK, you get to hear the patients' stories, then that's what we're aiming for. We can't just acknowledge that Fuller is nice to do, it's a dry document. This is how we're trying to breathe life into it for the population. So that's it from Holly and I, and thank you for listening to us.
Thank you very much, Linda and Holly. That was a very interesting presentation, particularly about, it's, as you say, it's how you get from the dry document to actually what happens for people. Has anybody got any questions? I'm not sure I can see hands. That's the only thing. So you might have to help, Suze. Any questions?
Yes, could I? Mary Bruin.
Hi, Mary. Yes, please go ahead.
I found the presentation very helpful and interesting, and I did look at the YouTube example last night. But I must say that with each new strategy and policy and report that comes out, I feel the weight, the burden of conflicting strategies and how they actually interrelate to each other becomes more and more difficult to see. And I don't know how patients are meant to understand what. I know that in your patient frailty model, you've suggested how this could happen, and the YouTube video certainly showed that. But there are so many initiatives. How on earth is anyone meant to find their way through anything anymore? And just on a minor point, I was quite interested to see the word geriatric seemed to be reintroduced on your last slide. And I didn't think that that was a term we used any longer. So, those are my points. I thought it was elderly care. Thank you.
You okay with that?
Yeah. I agree totally regards the strategyitis. I don't know if that's a word, and that's why the very first or second slide goes to the heart of the comment you've just made, Mary. It is so easy to get bogged down in just reading the strategies as a singular thing that we must do, and then develop a plan in a singular way. And I go back to my comment that I've never ever in my experience before heard the national leaders, so the national leader for elective care, all those waiting lists, etc., stood up last week and said, it's really important, of course it's important that we get to grips with the waiting lists, but absolutely we have to implement the new way of working that the Fuller Stocktake sets out. Because if we don't, we're going to continue to do all the things we've always done around waiting lists, which, let's be honest, hasn't worked. So I share your concern. I take comfort from the fact that the national leaders are telling us all the time, do Fuller, bring it into everything that you're doing. The work that is already taking place in Worcestershire gives us all hope, I think, and I believe. And because we have to start with the frailty strategy rapidly, because there are too many people in our ED departments, far too many, who are over a certain age, who shouldn't be there. So that's the imperative. And we believe that if we have got those frailty care coordinators, the social prescribers, all of those people on this diagram wrapped around that patient on a neighbourhood level, then that's got to be better than the wilderness they currently find themselves in, which you've described perfectly. So, yes, I'm being optimistic here, but it's on the basis of our developing this frailty model in a way that all the evidence says is the best way for patients to access care and to improve health outcomes.
Thanks.
Thank you.
Thanks, Linda. Chris Byrne, you've got your hand up.
Great summary, and strategyitis is a new word I'm going to be using in future, so thank you for that. I'd like to understand the role of the care navigators more in the implementation of the transformation plan, particularly the education side of the care navigators, because I would imagine that there's a lot of variation among them across the county. So how are you going about doing that, please?
That's a really good point, Chris, if you don't mind me calling you that.
No.
That is a central theme of our local recovery plan for improving access. And if you ever want to invite me back to do a session on that or meet with you separately, very, very happy to do that, because it is the building block to what we've just described. So we are currently putting in place training for everybody who's identified as a care navigator in each general practice, because if they get it wrong, then that means the patient just gets handed over to the wrong part of the service again. So that care navigator has absolutely got to know what services are available. They need to understand from GP clinical systems, well, hold on, this person has contacted this practice 3 times now. I need to book this person in with the GP, and the GP needs to see him today. So there is training locally and nationally. General practice has the same concerns. We're only 6 months into implementing this recovery plan, which is 2 years. I can see us having to change it quite quickly to look at a different, more resilient model of care navigation. I don't know what that looks like, but we know the turnover of these people in general practice is huge. So if we upskill the person and they leave, there has to be some way of continuing to develop and build the capability. So thank you for raising this. It's on our risk register and it's a really important issue.
Yeah, I think probably somebody from Healthwatch Worcestershire would like to explore that further with you, definitely. Could I ask a second question while I'm here, Joe? Is that okay?
Well, go on then.
All right, thank you. On the voluntary care and on the VCSE sector, I'm involved with the stroke redesign pathway, or I say I'm hearing what's going on in terms of the stroke redesign pathway, and the VCS area will be crucial from the rehab side of things. And I kind of wonder, I'm not hearing, probably, maybe we haven't got to that point yet, but I'm not hearing how the VCSE is linked in with the clinical pathway. So I kind of can see that coming into other clinical areas as well, where you've got a clearly defined clinical pathways out there, because the NHS is absolutely spot on when it comes to that. But then there's this sort of grey area where we want to introduce VCSE. I'm kind of wondering what that grey area needs to look like in a bit more detail, because the desire is there clearly, but where's the detail behind that? Does that make sense?
It makes absolutely total sense, and to expand on what you're describing is the trick and the opportunity, but also the challenge for me, Chris, because what we've described here regards frailty, you're absolutely right, has to be expanded to cohorts of patients in almost every category. I can't answer your question either, but I will take that point back to Mary Gay. if you're comfortable with that.
Sure. Yeah, thank you very much.
Thank you very much.
Joe. Thank you.
Simon, I think you were next with your hand up.
Thanks, Joe. I've got a couple of questions, Joe. You wouldn't be surprised, I'm sure. Linda and Holly, thank you for that really good presentation. I like drawing it all together for us, telling us where you are. Can I just take you back to slide 8 of your presentation, which was around the primary care networks? And I just really wanted to know the extent to which community teams from the Health and Care Trust, because you mentioned the importance of community nurses working alongside GP practices, and you can't understand that it would work any other way. But are they actually part of those primary care networks, or are they sort of operating alongside primary care networks? And the same with the mental health teams. And for example, the physiotherapists, the OTs, the speech and language therapists, they've got all those other community, but podiatry, all the other community-based assets they've got, which one would think for this model to work should by now, be operating within primary care networks and not necessarily sort of positioning themselves alongside, but not actually within. So could you just throw a bit of light on that for us? So that's my first question. You can wrap them all up at the end if you want when I ask the questions. The second question is, in your defining the voluntary sector in Worcestershire, and Holly, obviously, and Chris has underlined how important the role of the voluntary sector is in Worcestershire. But kind of having been involved around working with the voluntary sector for best part of, I suppose, 20 odd years in Worcestershire, we always kind of seem to define it as the sector that's based in and operates in Worcestershire, whereas we have, for example, the Stroke Association, based in the National Stroke Association, based in Worcestershire. And also, I know, has been delivering services for the County Council, to pick up Chris's point about stroke rehab. And it just makes me wonder, will the NHS want to include those bigger organisations who, there must be some benefit, if not only in terms of infrastructure building, because of their capacity and their skills and particularly their expertise around quality assurance, that you probably know has been an issue for us around primary care services delivered by the voluntary sector last year. So those are two questions. I mean, and the third question is, what can we do to help, both in terms of helping you deliver what you want to deliver within the system? So that takes you back to, where are these district nurses actually, are they as integrated as you would want them to be? And what can we do outside of the system with patients and carers to help? Okay, thank you, Joe.
Holly, do you want to answer the first two and endorse everything you said, Simon? And I can chip into the third as well. Do you want to do it like that, Holly?
Yeah, that's fine. But just to give you some insight, Simon, and to everybody else, when I mentioned that we'd structured ourselves across general practice to support the Fuller Stocktake, we actually have dedicated a couple of members of our primary care network teams to work in a more closer way with the Health and Care Trust. So we now meet bi-weekly with Kate Pike, who's in charge of the community neighbourhood teams. And we've done an exercise across both parts, so from a general practice perspective and a community teams perspective, in line with the Fuller Stocktake, to see just how integrated we actually are and where we need to be. And we're currently working, we've got a group called Proactive Complex Care, where we have partners from the Trust and from general practice there, and we're currently working through how we get to where we need to be. And you mentioned some of the other smaller services, they're quite difficult to align at such a small level, so we're agreeing again how we can work together for the benefit of the clinicians and the patients, and where it makes sense for job geographically. From a VCSE perspective, I guess that's down to the Voluntary Sector Alliance in some respect, in terms of how they navigate that membership, because from a general practice perspective, I work with the 60 practices in their 10 primary care networks, but then we also have other primary care providers that we sort of include in our meetings or our projects as and when we need them to for the purposes of their organisation. So I definitely think it'd be something that the voluntary sector could consider, and we'd obviously work with the most appropriate organisations that we can and have the opportunity to work with.
It's a question I'll put to Pete then when he does the presentation on the VCS Alliance. Because it does seem to me, I mean, what we're interested in here is obviously the best outcome for patients in the community.
Yeah.
And I mean, to be honest with you, I know Pete shares that view. And we'll come back to it, Pete, when you do your presentation.
Yeah, I'll put my hand up for that reason, because I think there's something about how to include the non-Worcestershire based organisations within the sector who play, especially in the children's area.
Yeah.
But I'll come on to that in my bit.
Yeah. Okay. All right. Thanks. And just one final point, if I may, Linda, just before you pick up and talk about how we can help. And this might help you, but in an example, only the other day I spoke to a patient who was really frustrated because the patient had rung their GP practice wanting to have a conversation with a GP about a long-term condition they've got, right? And apart from you're 16 in the queue, we'll call you back, and then missing the call back and having to go round the loop again, it was about 3 o'clock in the afternoon by the time the patient got to speak.
Simon, you've gone mute.
On mute.
I've just unmuted myself. I don't know whether I'm allowed to do that, but so what I was saying was the patient had this frustration of going round and round the loop, and then when they got to speak to the care navigator, despite the patient saying this is not an urgent issue, the care navigator and effectively the practice insisting that the patient saw a GP that day. Now, and the patient did, and had a very good consult, I should add. But the point is, that patient's view was, well, I'm taking an urgent appointment here when I don't need to, and it's very inconvenient to me. So we need to move towards getting to a stage where some of the practices that the more progressive surgeries have introduced in Worcestershire, which I know exists, is across the piece. Sorry, back to how can we help you?
Well, can I just comment on that example you've given, Simon, first, please, because that to me sums up what the National Recovery Plan is trying to do and what our system plan says, because our system plan says, you look at the averages of the National Patient Survey, oh, great, we're sixth in the country. Isn't that wonderful? But you break that down, and the variation is huge and very worrying. So, what you've described, if you can bear with me for a couple of minutes, I think is, on the National Patient Survey, we score 56% on ease of contact to your practice. Because how can you get anything if you can't get through to your practice anyway? So the national average is shocking. It's only 50%. So again, you could think, oh, well, we're 56%. No, that isn't good enough. It's not good enough. So through this recovery plan, we are now looking harder than ever before at where that variation is. The rescue plan, in my mind, is all the support that's available, nationally funded, to help all practices get to that position that you've described exists in others. So each PCN has got an access improvement plan. We're monitoring that. There needs to be evidence on the changes and the improvements made. There is the very clear need for engagement with PPGs, for PPGs to represent the practice population, for engagement with Healthwatch. Many of the PCNs have said they will engage with Healthwatch to help with independent surveys, if such a thing is possible, or to guide on what kind of questions should they be answering. So there's there's a big role there, I think, both assurance to tell us, the commissioner, is it happening? Is it working? Is the funding being used to do the right things? But also in a supportive way, if you have got any ideas and thoughts on how they need to reconfigure their PPGs or any other aspect of delivery in particular. So what we are planning to do, going back to the improvement plan I just mentioned, we will be reviewing delivery where all PCNs are up to in their plans. I think it's March. And we will be putting in place the panel that we set up last week to review the applications we'd had from all 79 practices. I think 71 came forward in the things they want to do to improve access for patients. So we'll be asking you to join us to say, yeah, we think this PCN, those practices have delivered. So I think we're on a journey here. I hate that expression, but this is a 2-year program. We're just getting into it and really value your role as the voice of patients, what you're hearing, and correlating that with the data and our knowledge of practices. Do you think that might be possible?
Yeah.
Joe, shall I certainly have a conversation?
Yep, Don.
Yeah, certainly have a conversation. I mean, Don will pick, as you know, Don, you may know Don from his previous career, but Don will pick that up. Sure, Don's pick that up with you, and was more than, I guess, sort of helping you do that, and giving a view is fine. It comes to when we get, I don't know, practices saying, can you come along and can you actually, do some work around our PPG for us? We'd probably say that might be a step too far, just because of the resource. And also, at the end of the day, they need to do it themselves because they need to walk it. They almost need to live it and walk it themselves, don't they, to make it work?
Yeah. I have 2 more questions. Have we finished this? You okay with that, Simon? With your questions?
I'm fine, thank you.
Linda, are you okay with that? I've got 2 more questions for you, and then we'll move on to Pete's bit of the presentation, if that's okay. Julia.
Yeah, I just, as someone who sits on NHS committees, as a volunteer and expert by experience, I've made the observation over the last few years that you are literally creating more and more new committees all the time. And what concerns me, because I've witnessed this, is that there's so many committees and sometimes they're linked and the information is lost between the committees. And I, as an unpaid volunteer, I seem often to have to point out things that have been lost. And so I think you need to improve your communication. And secondly, I love the frailty model, but if I just took out the social workers who I work with already, I know they're already overworked and they can often only see urgent cases. So I'm not quite sure where you're going to get them from, or the funding, which we all know is very low for social care.
Thanks, Julia. Linda, are you okay with that one?
Yes, yeah, totally agree regards the governance and the bureaucracy. I think in being re-established as integrated care boards, we've generated a lot of governance, a lot of groups that are reflected then in Worcestershire, the same in Herefordshire. We need to review that alongside what our duties are as an ICB. I'll take that message back to our head of corporate services, but totally agree, because sometimes I find myself just writing reports to many of them instead of doing. As far as the reflection on workforce and funding is concerned, absolutely critical. So we know that in order to deliver that frailty model, and it comes back to the comment made about geriatricians, we haven't got as many as we need given our demography. So implementation of this includes a training programme and upskilling people and changing job plans in the acute. Glenn Burley, new chief exec of Worcestershire Acute, has given his commitment to doing that. I read with interest in the Health Service Journal this week that because of the funding issues in the local authority and patients not being able to get back home out of hospital, that one foundation trust in the south has actually developed its own social care team. I think that to me is an example of, if we keep doing the same old things, nothing's going to change. We need to be innovative, bold and brave. Funding, you're absolutely right, Julie, but if we keep paying as much as we do for all the ambulance handover delays, for all the people, especially over a certain age at the moment in Worcestershire acute, if we could use that funding or some of that funding to implement this model, finance would not be a problem or so much as a challenge, because we're spending a fortune on the wrong kind of care.
Thank you.
Thanks very much, Linda. And I think the final question on this section is Jonathan.
Fabulous. It's a question I will ask Pete. He comes up. It's a question I've been trying to get to the root of since early summer. So, question for you, Holly, around strategy then. First of all, I recognise the strategy-itis. And as someone who's had a kind of military education, I would recommend reading Clausewitz or Sun Tzu or Yomi to recognise what strategies really are. They're not difficult to understand. I think we've over bureaucratized them in the modern world. There we go. So my question is, Holly, you talk of the voluntary sector, and in the conversation you've had, you mentioned social prescribing, Age UK, and frailty coordinators between you. That's a very, very narrow view of what the voluntary sector is. My question is, what is it of the voluntary sector that the health service want in this much talked about equal partnership? What is it the voluntary sector have that you don't have that you need?
Thanks, Jonathan. I think just to reiterate, in the context that I was talking about was how general practice has worked with the sector currently, which is on social prescribing and is on the mental health projects. Obviously, I absolutely understand that the sector offers much more than that, and the sector benefits from working across the NHS with other partners, but I can only give my experience of working with general practice and the opportunities that we've had to work with the sector. And in response to your second question, I think that it differs depending on the population, doesn't it? So that's what we've seen across the district collaboratives. We've seen the difference in health priorities versus the difference in opportunities across districts. You know, in Whithaven, needs and opportunities might be different to Redditch. So I think it really does differ based on where you are and the partners that you're working with. And obviously, I can only speak from a general practice perspective. I'm not, I'm not part of the other organisations. The other partners in the NHS might have a different view on working with the sector. I can only give my views of what I know and what I understand locally.
So, can I ask then, is it the voluntary sector's reach into communities that the NHS wants? As if you will, if you talk of strategy terms, Holly, you'll understand core capabilities, won't you? So is it the core capability of the voluntary sector that we can reach into communities, or is it we can do things cheaper? Is it that the NHS wants stuff done for free? Some things done for free. Well, this is important stuff because I think it's impeding the collective intellectual progress of the Alliance. It isn't quite clear what is required from the voluntary sector by the NHS.
I'm not sure I can, I'm not sure I'm the most appropriate person to respond to that, Jonathan, if I'm honest, because as I say, I work in general practice with the primary care networks, and I haven't got a wider view on the whole of the NHS. You know, that is for other people, I think, to respond to your question, Jonathan. I understand what you're saying, but I can't answer that question from my role to do it justice. But I know that from a general practice perspective, we haven't expected anything to be done for free. We have invested funding that we have in our remit to support where appropriate. And that's all I think I can say, I'm afraid.
I'll lay off the Holly. I'll pass that question to Peter Sugg because he chairs this alliance and he can answer it.
Yeah. Did you want to say something, Linda? Sorry.
Yeah, I'm not sure that I can answer it as precisely as is needed at this moment in time. But what I would say, Holly is absolutely right. This is why identifying the needs at a neighbourhood level, district level, call it what you like, is absolutely important and imperative to then understand how partners can best use their skills to be able to support that person, that community. That sounds very much motherhood and apple pie, doesn't it? But if we use the frailty example again, because that's real, it's going to happen. Care coordinators are funded by the NHS. What I did in my presentation was I added frailty in front of it, because in that way, PCNs in the integrated neighbourhood teams know it is that person who will be coordinating the care, the appointments of that particular cohort. As far as funding is concerned, if again, the Northamptonshire model, what I am clear upon there is they used existing pots of money once they'd identified the cohorts and the needs to be able to fund a delivery model. So they used existing funds in a different way once they were clear on the needs of the population. And the ICB, with its partners, is intent on doing the same this year in its quite different, radical and bold financial strategy, where we will see, despite the challenges, investment standards being awarded differently to recognise integrated delivery. And that piece of work is also ongoing and has been discussed at the ICB board as recently as February. So work in progress, but some fundamental questions there to ask when we're looking at the various patients, cohorts of patients who are our collective responsibility.
Thanks very much. Thanks very much, Linda. Simon, you've got your hand up. So one final thing, and then we'll move on.
Well, this is relevant to the
conversation
that's just going on, and I wanted Linda to hear this as opposed to something to raise with Pete, and that is, over the last 12 months, we have had some concern about some services that the voluntary sector has been providing for the NHS in terms of quality, and the thing that comes out of that is it must be incumbent on the NHS, and this is a shout out for the voluntary sector, to properly fund those services so they can be delivered from a quality perspective. And it's absolutely right. I mean, we know we've got Speakeasy now delivering the Oliver McGowan training for us. It's absolutely, they're probably some of the best placed people to deliver that in the county, given the experience you need to be able to deliver that. But it's absolutely right that you must fund it so that it can be delivered in a quality way and not be seen, we don't want the response back, well, we gave it to the voluntary sector because it was cheaper, to do it that way. Because we can't expect a quality service to be delivered if they don't get properly funded to do it, can we? So there's a shout out, Pete, for the voluntary sector there.
Thanks very much, Simon.
Thanks. That was a statement, Linda, not asking you for a response.
All right, Linda, is there anything else you'd just like to wrap up with? And by all means, if you'd like to stay for Pete's presentation, that would be fab. And you too, Holly, but also understand that you're busy. So
I'll leave. Thank you ever so much for the opportunity again. And any further discussions about any of the recovery plan, etc.
And I'm sure we will be inviting you back. Thank you very much.
Thank you.
Thank you, Holly.
Bye.
Thanks, Linda. Pete, it's over to you.
Okay, yeah, brilliant. Just Susie, have you got anybody waiting in the waiting room? I think Chris Roberts is trying to get in.
Oh,
There's nobody showing Pete in the waiting
He
room.
sent me a note and I said I just sent it now, just pass it on. He was trying to get into the meeting, but there you go.
No, I've got my eye on the waiting room, but there's nobody there.
No problem.
you're having trouble with the link. Sorry.
No, he says he got the link. He's sat in a waiting room,
Oh.
drinking tea. Do you, Susie, are you sharing the slides?
Yes, yeah, we'll be sharing the slides for you, Pete.
You want to go?
Sure.
Go for it.
Shall I just introduce you, Pete?
Yeah, go on then.
So Pete's going to has kindly agreed to do the presentation from the Worcestershire Voluntary Community and Social Enterprise Alliance, of which he is chair. He's also chief executive of Young Solutions, see the wall behind. And Peter also is one of our co-opted board members. So just thought I'd introduce you, and he's going to present on sort of how they see their vision and how they're going to work with the Fuller Stocktake and the whole sort of integrated care thing. So over to you, Pete.
Cheers. Okay, so here's the slides coming. Just to say, I'm obviously doing this presentation because Esther's poorly. So this presentation is a combination of the one we're doing around all the district collaboratives, and obviously with some Fuller stuff there as well. So first slide, second slide, next one, please. Okay, so this is an overview of the presentation, and this is the thing we do normally, but then you've got this Fuller thing at the end. So just going to go through those 7 bullet points, and then we'll go from there. Next one, please. So the Alliance launched in July 2022 with 25 VCSE leader founding members working together to help shape the Alliance and its future work. Interesting point earlier about, which I'll come back onto at the end, about who the organisations are, because they are all, in order to be on it, you have to be based in the county and have an office in the county. So one of the points I want to raise later on is about how it's come up earlier, how we actually utilise all the other volunteer organisations who are working in the county, particularly around the children's agenda, which again I'll talk about, who aren't involved with this process. So I think at the moment that's a weakness. So next one slide, please.
Sorry, I am
Is it moving?
just having a moment.
Oh, is it moving?
There we go. Sorry.
Beautiful. Thank you very much indeed. Cheers. Okay, so why is it important for VCSE is involved in the integrated care system? And list there in terms of 2,000 VCSE organisations across the county, delivering a vast number and range of health and wellbeing services, experience of working in partnership, strong connections with communities, and VCSE workforce has huge amount of knowledge and skills. Next slide. So as the VCSE Alliance emerged, this is the current vision, aim. These are the current vision, aim, and objectives. So I won't read them out, but basically, in terms of, we can send these slides around later so that people can digest them. But this is our script. So next one, please. So when the Alliance was formed, led initially by Roger Britton as chair, the 6 work streams have emerged. So we've just got a little bit going through these 6 work streams in a moment. Okay, next slide, please. So first one there in terms of, this is similar to the one that Holly showed in terms of representation, integrating the VCSE. So Hereford, Worcester wide, Worcestershire place, and then district and neighbourhood. And again, the various things that are there, particularly ICS Academy, which we'll refer to in a bit. But this is how it's working across the sector now. When I did this presentation in Redditch to the collaborative, I said, that's a lovely step chart, isn't it? So in terms of, it's a way of trying to illustrate basically how we work. So you start with research, recommendations, VCSE strategy, delivery plans. The Alliance is working with a multi-agency steering group to undertake research to inform VCSE's strategy for the sector. So again, as people who know me, this probably isn't something I would have produced, but it's really good in terms of showing how we're impacting on the community. So next one, please. And in terms of the community wellbeing roles group, which quarterly has a get together and a little feedback there in terms of the July check-in. Really found this useful. Nice to talk about our own well-being. So again, it's having impact across the county. Next one, please. Next slide. So, other thing we're doing is coordinating VCSE mental health providers, and there's a pie chart there in terms of managing emotion groups, mental health link workers, and peer support program. And then a little paragraph there in terms of what it's trying to do. An example there of the Age UK gardening group. Next one, please. So the current work currently funded up until April 2024. Expansion of mental health link workers, 3 bullet points there. Expansion of managing emotions group program and peer mentoring program as well. So those are things that are currently funded until 2024, and we'll come on to overall funding in a moment. Next one, please. Future mental health work. The Trust tender due in 2024 to support mental health delivery across Herefordshire and Worcestershire through VCSE integration. Work ongoing to strengthen VCSE organisations, quality assurance, monitoring, evaluation, compliance, brackets, information and governance. And again, back to Simon's point, again, basically the amount of funding will if there is any funding, will impact on how much and is it how much of this is actually done. Next one, please. So the Worcestershire VCSE mental health provision report, phase 1's completed, and there's a copy of it, done by Worcestershire Association of Carers, and then completion due of the second phase. It's reported by district, and it includes workforce systems, etc. Next one. Okay. Community-led research and engagement project, another one of the strands. It's a 1-year project too, and then there's 5 bullet points there, and that's currently being undertaken. Next one. And now this is a special bit for this bit of the meeting, but obviously I spoke to Simon before about wanting to inform Healthwatch as to exactly what the Alliance is trying to do. So in terms of Fuller and the community-led research project, development opportunities, there's a list of the things that this work can be used around the Fuller themes, aims. So there's that. Next one. So there was, as we referred to earlier by Holly, there was a Fuller Stocktake workshop in July 2023, and again, 4 points there that came out of it in terms of building integrated teams in every neighbourhood, delivering the change our patients and staff want and need, improving access for urgent care, preventative healthcare and early intervention, creating a national environment to support locally driven change. So in terms of from that workshop, I think you can see all these, but basically this is the information that came back from people within their workshops, and Jonathan had a big input into this in terms of moving this forward. So again, for people, you might want to reflect on these later as to what came out of that workshop and how the Fuller report impacts on this. Next one. So phase 2, direction of travel. VCSE Alliance strategy based findings from research evaluation and partners input. Develop a system to share more VCSE sector intelligence and data with partners. Explore innovative approaches to maximise investment into the VCSE. Develop a thought leadership model incorporating VCSE representative insights and knowledge. VCSE faculty, which is the training faculty, a wide range of training and development opportunities, which a number of us are already involved with, and is really a positive thing in terms of access to training. Next one. And there's information in terms of basically, if you want to visit WorcesterAlliance.org to register for our monthly updates from the Alliance and the wider VCSE. That might be it, I think. It is. So, any questions?
Right. I'm going to take chair's privilege and ask the first question.
Okay.
Do you feel that you, within Worcestershire and the ICB, that the VCSE is being fully involved in a co-production sort of way? And do you feel that there are any sort of potential opportunities that are being missed? And do you feel that there's enough sort of help with capacity, I suppose, capacity development?
Very interesting, because as you know, I come from a children's background, and even as a starting point, I'm not absolutely convinced that my definition of co-production is the same as the definition of the ICB. So I think that's a personal sort of view. But actually, particularly around the training faculty, we've been heavily involved in that process. And I've stopped saying it now, but for a number of meetings, I kept saying this is too good to be true. So that bit is good. But I think particularly around the funding side, which is still being up front, is in abeyance. I think there is an issue in terms of going back to some earlier points. There is definitely an issue in terms of what are they going to pay for. So I think there's certainly a long way to go. But I think, especially having come into I'm the only representative of the children's voluntary sector on the group, so there's 20 odd other adult voluntary sector guys. So it's been really interesting in terms of how this works. But I do think there is something about this is a sub-term, putting your money where your mouth is, in terms of it will be interesting as to actually how much funding is available to do this. But I think there's a genuine agreement to do it. But going back to some of the earlier points people made, it's a bit difficult if it's on the cheap.
Thanks, Pete. Debbie, you've got a question.
Debbie?
Yeah, I just wanted to know, Pete, what are your plans sort of around working with other sort of charities like Action for Children, Barnardo's, who are obviously involved hugely in children's services locally and rely on volunteers? Yeah.
Well, that's exactly my earlier point about, I couldn't believe it when we first set up the Alliance and I was vice chair, that I was, Young Solutions is used to representing the sector, but in all our children's and young people's work, all those significant providers national providers who happen to be in the county, and you just mentioned Action for Children, Barnardo's, YMCA is another one, etc., they are on those groups. So we were on a Wychavon Youth Forum last night, 26 organisations represented, 3, 4, 5 of which were national ones who happen to be based locally. So one of the things that I'm looking to pick up for the Alliance is how do we get the voice of they are local, but technically the non-local providers. So because certainly in my world, especially through all the children's centres over the years, the two you just named have been absolutely significant. And again, with things like half of the play stuff, etc., those two organisations are key providers. So I think it's absolutely, somehow we've got to find a way of getting local national providers with local input, and Simon referred to this earlier on other things, to be able to have their say.
Okay, thank you.
Thanks very much. Simon, you've got a question.
Yes, got a couple of questions, as you might expect. The first one, Pete, is thank you for the presentation, right? But I still got a bit lost on, if I'm a small voluntary sector organisation in Worcestershire, right, set ourselves up to support group, and there's 1 or 2 represented here. What exactly do we get out of that? We're not looking to do business with, and there are a number of organisations I know who deliberately choose not to do business with the NHS or with the, they don't want to follow the money, as some people describe it. what's in it for them? What's in it for them? Because as you know, we've got best
Yeah.
part of 100 organisations on our reference and engagement group.
Mhm.
Some of those are already members of the Alliance and very active
Yeah.
members of the Alliance.
Mm.
Others won't be. Others are very small organisations. What's in it for them? And where's the capacity build? Who's funding the capacity building? So when they come to us and say, I need some support writing a bid, for example,
Yeah.
where can we send them to get that support, or they want some support with their governance?
Yeah, I think there's two bits to this. One is going back to the
and you might have covered it, Pete. Let me say you might have covered it, but even for me, you lost me a bit in that presentation. I'm sorry.
Well, no, and don't forget, I'm reading
A lot
out
of detail there.
I'm reading out somebody else's report
Yeah.
presentation. So, but from a sub perspective, especially around the young people and children's agenda, if we've got a small if we've got a village hall youth club, we've through our core contract, we basically provide support and training to enable people to build their capacity within their club. So putting that wider, one of the things through this faculty training is actually finding a way that people can access training either cheaply or free of charge, like we've always done as part of Young Solutions. So I think the big issue is where, after the 1st of April, where does the funding come from? So you were seeing on those slides, most of it is time, a number of the projects are time limited and the posts are time limited. But in terms of being able to build up the equivalent of what we do for the young people's sector, there is an issue about how it's funded. But the idea is, and especially around some of the things around the mental health stuff that's emerging, is about collaboration, so that those organisations that aren't in a position to, for want of a better word, stand on their own 2 feet, can be supported to either put in their own bids or work with other partners who they can work with. So I think it's an interesting point in terms of how can we build up the capacity of people who can't automatically do it themselves.
Okay, right. Thanks. So my second question was about mental health stuff, because we clearly got a really close eye on that because of it's been a priority for us for a long time now. I'm really interested to know how the NHS is going to try and use the voluntary sector to actually deal with some of the waiting lists for talking therapies and stuff like that. And a lot of patients would say, well, actually, I want to see if that, I want to actually get access to clinical therapy, not necessarily want to be helped along the way by somebody from the voluntary sector.
Yeah.
So there's a big communication job there.
Yes.
You talked about in your slides, and again, I appreciate they're not your slides. There was a slide around, and I know you haven't been that close to the mental health stuff, but there's a slide around developing the mental health but in advance of a contract coming up, being offered. And what I'm interested in is who's funding is the NHS being funded to get its act together, if you like, in terms of what it's doing out to provide NHS mental health services, or are you having to fund that yourself, that development?
No, there was a slide about halfway through the slides, a thing about we're awaiting what this local funding is going to be in terms of, and it's going to come out of the trust in terms of trusts. Right. In terms of, so we had those pilots, and then I think there's been a bit of confusion about the money still hasn't emerged. Now we've got Sophie Wheatley who's doing the initial stuff, and there's a pilot in Redditch because of their waiting lists, etc. So what we could do, I mean, again, in terms of specific detail, we could get Sophie to come to a meeting.
Okay. Or we could have a meeting offline, but there is. So the NHS is effectively not expecting the voluntary sector in Worcestershire to invest its own resource in developing,
not
so that it can get itself in a position where it can contract these services.
What we're waiting for is basically a tender spec that says, here's a significant amount of funding for additional mental health support. My concern personally is still, how do the smaller organisations get supported?
Okay.
And collaboration is the thing that the providers are keen on, but how does it actually work? But time will tell.
Okay. Thank you.
Thank you. Jonathan, I think you had your hand up next.
Peter, I'm picking up a question Holly earlier. And you've just said that funding is uncertain. I think you said that it's not clear what they being, I guess, the NHS, are to pay for. So my question is this: what direction have you received as a management board, as a chair, from the NHS about what exactly they want you to do for the money? Because this is a significant amount of public money that could be spent on other things. We know the health service is up against it.
Yeah.
It's clear to me in your presentation or Holly's what it is we're expected to do.
Yeah. And I think what's also interesting, especially with that list of projects, is the current work is only funded till April, apart from the core funding for Esther's post and a couple of those research projects that's gone a bit longer. So again, part of what we're waiting for is the ICB decision as to what happens next. So I think we are definitely in a transition process as to, there was this initial thing about the alliances being set up a couple of years ago when they first started, hence those slides. And then, but what happens next, I think is interesting. There's lots of discussions going on, but I don't see anything specific emerging yet that says what happens next.
So Pete, did you, just to answer my question, you haven't received anything from the NHS? No, nothing.
No, not other than ongoing dialogue, and I think it's due to go back to the board in the new year. But I don't. There's nothing that says what we're doing now. How long is that going to be is that going to be refunded, or are other things going to be refunded? Are we going to be asked, as you say, to do other stuff?
So I just wondered if Healthwatch can help out here, Simon, because it seems, I'm sort of. It would seem to me that the health service have provided money to the voluntary sector without a clear understanding of what they want to deliver in receipt of that money. That seems peculiar, given it's public money. Is there something Healthwatch can do here to help the voluntary sector by asking the questions of funders?
To be honest with you, Pete, I was going to suggest, one last question I would have asked you, but I could see the chair was getting she was giving me that stare. Right?
That's enough, Simon, that's enough. Yeah. Okay,
one of the things I was just going to ask you, because Linda threw out the invitation to us to actually sit on the PCN review group. And I wonder, obviously, you'll be evaluating, presumably somebody will be evaluating this mental health, the money that's come to you to do this work on mental health. Certainly an offer from us, I think, to sort of participate in any evaluation of that. Particularly from a patient perspective. But also, it does concern me if the NHS are actually asking the voluntary sector, sort of throwing the money out there, but not actually giving you some specific terms of reference about what they expect. How are you going to evaluate? How do you evaluate what you've actually done?
So there's the initial period, which is what those lists are all about in terms of what we're doing. But in terms of how we move it forward, particularly around, and the Mental Health Commission is a prime example, how does that, when that's commissioned, how do we fit in? But even in terms of the alliance bit, and the alliance's role, as it stands, other than, as I said, Esther's post and a couple of posts that have been funded to go into the new financial year after April, there isn't any funding. And certainly because, and Jonathan knows this well as well, is that because of the sort of commitment for us all to buy into it voluntarily, it's taken up a lot of time. In terms of supporting it as an entity, supporting the alliance as an entity, because we're all obviously doing it voluntarily, literally voluntarily,
as well as the rest of the day job.
Correct.
Okay, Jonathan, was your comment to carry on this theme, or was it on something else?
My hand is up again. I have another question, actually.
Oh, okay. So can I put you back, because there's a couple of people ahead of you? If it was the same theme, thank you. Gaynor, you had a question.
Hi. Yeah, but sorry, my camera's not working today for some reason. Yeah, we had a meeting with Jack, whatever his name is, I can't remember his surname off the top of my head at the moment.
Would that be Wainwright?
That's it, yes. So there was a meeting talking about funding just recently that there is discussions, and the funding that did come in went to specific groups. Only certain people was given the opportunity to bid for it. So people that was doing things like delivering the MEG project, for example. So there was certain organisations, like the bigger ones, like Onside, Worcester Carers and Mind.
Yeah.
They could only bid for those particular things. As for training, I've looked at no end of things on the part on the website, and it's not easy to get any of the training that's been offered, because I've just been on there just this second and just been clicking on some of the links. I can't get anything. The McGovern training, because I don't have an NHS account, you can't get it. So you've got to go through somebody else. So it's all awkward.
Yeah.
Because the charity operates in Worcester, but because I live in Tewkesbury, I've looked at the Gloucester one, and I've received training straight away from that one. It's all easier to establish, and I know what's going on. I go to majority of the meetings that I can, and you was just talking about support for smaller organisations. I have mentioned to Sophie, I've met up with Sophie Wheatley, and I don't see what I'm getting out of it.
Right. It might be worth sort of picking this up offline so we can actually get the specifics of your particular needs. But that is a really good point. One of my things all along is about trying to make sure that smaller providers do feel they can access the same training as training and support as the bigger providers.
Yeah. Is it do you know each other, or can we give your contact details to
I don't think I know. So let's meet up.
Yeah. If that's okay, Gaynor, we'll give your contact details to Pete.
Yeah, that's fine.
Thank you very much, Gaynor. Cheers.
Thank you.
Joe,
John,
can I just help you out here, Joe, and say I think Pete's taking some questions here that the NHS should be answering, really.
Yeah.
Well, yes.
Maybe we.
That's okay. That's all right, Simon. That's okay.
I say, is it not Sue Harris and Ruth Lemachek?
Yeah, I just had a note directly to me in the chat that basically, and I was going to clarify, is that there's lots of things being discussed, and there's a name quoted here, Simon, from the good old days, Richard Keeble, in terms of his, and I definitely know him. So there's lots of things going on in the background, and what I was trying to get at earlier was that there's nothing concrete yet. So it's not as if we're being ignored or no one's talking to us. But one of the other things, interestingly, in this direct message to me is about clearly defined projects which may be fixed funding time limited, which is very similar to the ones that I had on my bullet point list of the projects we're doing. That's like all of us know, in the work I do, is that's reality. But what I think is we're still waiting for is that longer term funding. I think Jonathan was getting at, in terms of what are we expected to do as an alliance on a core basis, not on a project funding basis, because even up until recently, Young Solutions can't be doing stuff if it doesn't exist. So I think that's the bit that we're waiting for overall. Anyways, a few more hands up, Jack.
Yeah, thanks, Pete. John.
Thanks, Joe. My point was going to be around the one Simon's just made, actually, that a lot of this seems to be NHS stuff. And there needs to be further conversations with them about the clarity that's needed for how the voluntary sector can do things. I don't know if, Pete, you can say, from the early slide, you said there was about 2,000 organisations in Worcestershire in the voluntary and community sector. How many of those are members of the Alliance now?
Don't know. I can get you that answer. I know there's been a lot of membership stuff coming post the assembly, but I'll get you that answer.
Yeah, I just wondered in terms of how they were able to get the information, to get the support, and then to have a body of opinion that might have some weight behind it.
Right. So you've got the newsletter and the website and all that sort of information, etc., that gets sent out. But in terms of how I'm still, even as chair, I'm still interested about how actually those small organisations have a voice.
Yeah, yeah, and those that are
still emerging,
particularly working with communities that will be in touch with patients and service users and so on.
Yeah.
And I think you've probably touched on it, Pete, but in terms of capacity building and training, is there been much thought given to the focus on the quality of services that can be provided by the voluntary sector?
Yeah, and I think this is my bit about, as I say, I've stopped saying it, but I'm going to say it again, is that faculty, the specific faculty for the VCSE within the training model that's coming out of the ICB is too good to be true, in the sense that basically this training is going to be made available to the sector at the highest quality. So I know Jonathan's been at a few of the meetings in terms of how that's moving forward, and it continues to be positive. So I think for one, certainly a lot of the training that we were able to access via the county during COVID, that seems to be definitely potentially available as we move forward into this faculty, and Esther chairs that particular faculty. So yeah, as I say, I'm going to stop saying it's too good to be true, but it's potentially too good to be true.
Thanks, you, Pete.
Jonathan, I think we've got 2 more questions, and then I think we'll again have to wrap this up if that's okay. So Jonathan.
Okay, thank you.
Pete, just to pick up on a remark you made about training, I agree with you that training is great and we should get it. I wouldn't agree with you that so far what we're seeing is anything other than, well, bureaucracy, frankly.
On the training side,
yes, we're still wrapped around complicated slides and complicated delivering training to voluntary sector organisations ain't difficult. But the NHS is making it difficult for reasons I don't understand. I think that's another question, Simon, we need to ask our NHS colleagues to explain. How difficult are we making this for the voluntary sector? Yeah,
and one of the things I'm slightly concerned about, even though I'm answering it, is about we shouldn't always be grateful. We should actually it should be our right, but it's the bit about having been in this world for a long time, especially with young people, children. You know, it doesn't always manifest itself that training is accessible and affordable. So that starting point is great, but you're dead right, Jonathan, is that sometimes some of the stuff we do now, we are a little bit, it might feel like we're going around in circles. We need something a bit more tangible.
Thanks, Pete. I won't ask you more questions. Thanks for coming on.
Thanks very much.
Giving you a hard time.
Okay, thank you. I think we'll take this for the final question, if that's all right. It's Morag from Speakeasy Now.
All right.
Oh, sorry, trying to unmute myself. Yeah, it's more of a comment really. It reflects on what we were talking about earlier in relation to the NHS and the structures around the community neighbourhood teams, and it's just a sort of thought about the engagement that obviously the NHS and more widely want to do with the voluntary sector, which is great, but it's the capacity and the capacity for us as voluntary organisations and for smaller organisations who might be operating across Worcestershire and potentially Herefordshire as well, is how we have the capacity to get involved in and give feedback on all of these things that are happening, have that involvement, but at which level as well, because if you've got all the different district collaboratives, then you can have, we can have a conversation with one of them. So I had a conversation with Redditch about mental health and going back to earlier comment about communication. So then you end up telling them at that local level what's being done across the ICB, obviously in our case around learning disabilities and mental health, but we haven't got the capacity to have those conversations with all the district collaboratives and engage in all that different work separately. So yes, it's just about what the Alliance can do really to sort of support that communication of information and engage and how we can meaningfully engage at the right point, really.
Yeah, and that's a really good point in terms of one of the things Simon said earlier about actually talking to the NHS, because one of the problems that we're getting now is that this is Young Solutions. We've always had a representative role. So going to all these meetings is what we do. But our new contract says we're not supposed to go to all these meetings. We're supposed to concentrate all our time on youth work, which is great. But again, you know, people say to me, "What do you do? Why are you here?" Well, representation is our role. So I think again that the whole capacity thing in trying to go to all those collaboratives, in our case, go to all the youth groups, etc. When do you do the day job? So I think there is definitely an issue around how do we, especially for the smaller providers, how can we be both enable them to get there, but also to be their voice?
Yeah. Thank you very much. Are there any further questions? Oh,
yes, Joe, there's a question in the chat from Paul Eccles.
Yes, it was about funding, wasn't it?
Yeah.
Where's that?
Yeah, who's in charge of the NHS funding to the Alliance, please? I don't know if Paul's on the call, and well, he is on the call, whether he wants to unmute.
Does Pete have a surname? It says here, Pete Sugg.
Oh, no, so yeah, Pete. Yeah, that's Pete Sugg is Pete Sugg. But the previous question was from Paul Eccles, asking where the funding was from the NHS.
Right,
for the
so
Alliance.
it's come from a number of sources, but currently the ICB is talking about basically what happens next. But the funding that got it going came from the integrate what's it called, the Sue Harris, in terms of with some of the funding. So basically the various partners locally, county, health, etc., are putting in elements of funding, but the ICB bit at the moment, they're not giving any funding, which is the discussion that's going on at board level now.
Yeah. Thanks very much. For transparency, Paul Eccles said he's a journalist.
Oh, okay, right.
So Simon, what's the best way of wrapping this up, do you think? Do we need to have discussions outside about how this works? Do we need to give people swap contact details so the smaller organisations can talk to Pete? Where do you think we need to be?
Well, I think first of all, Pete, we can help you. I mean, we've run Esther's contact details in our bulletin before promoting. Yeah, so we'll do that again. All right. Particularly if Esther can send us something about the offer to those small organisations, because there has to be what's in it for them.
What's the offer?
And I've got to say, I think listening to Gaynor talk about the training, you might want to have a look at that before we start promoting promoting all of that. If it's not quite as simple as saying you can go to this.
Well, I think Jonathan's right in terms of the fact that it's still in transition.
Right. Okay.
So we've not physically seen what the offer is.
Right. Okay. So we need to make sure whatever the offer is, or whatever it might be, we provide some accurate information. We can do that.
Yeah.
The second thing is, we sort of really would welcome the opportunity to come alongside some of this mental health stuff that's going on from the evaluation perspective, and to better understand that. And then in terms of, some of the questions we put to you about what you're being asked to do, particularly around capacity building, are probably questions that we need to ask of the ICS.
Yeah, because that'll be the next.
Yeah.
So,
that might be something. That's something for a future board meeting. So I think there's a lot. You've only got to look at the numbers that have attended this meeting. We've got a lot more people here than we usually have at a public board meeting. So obviously, a lot of interest to people. So I think we should do that at a public board meeting.
Yeah, agreed.
Yeah, maybe in January, the next one.
Yeah.
Okay.
Yeah. Because I was going to suggest to you that we invited the Director of Public Health to the next public board meeting to talk about supporting adult health improvement.
Yeah.
Got a big role for the voluntary sector in it, providing it doesn't cut across her tendering timetable. Of course.
She went.
You might be sensitive about that if
need to be careful.
Chucking information out there, but that's where I always suggest we deal with that. Thank you, Pete. For me, thank you for taking this on, because I know
no problem.
We only found out you were doing this.
No problem.
This morning.
And apologies about my bandage, but I've just had a melanoma taken off my face. But I thought I'd just keep the camera on. Gaynor still got a hand up, Joe.
Have I? Oh, I've just got. Sorry, Gaynor. Yeah. I think it popped up again.
Yeah. I just wanted to say that currently most of the funding for the like things like MEG training and that is being focused mainly, although it is in other areas, it's mainly focused around Redditch area. And so then Worcester City itself is not getting the chance, the people that like I particularly support are not getting the chance to have this opportunity. And so then it's taken them months and they are still on online training instead of face-to-face.
Okay.
Okay. I think it's, again, that's something that's probably dealt with in detail, because I don't suppose you actually know the answer for that.
We'll pick this up offline, yeah. And
okay.
Lee still going?
Lee?
Yeah, I was just going to respond to Gaynor. So what's happened is the MEG it's been rolled out. Primarily started off in Redditch. That was meant to be the focal point, and then to roll it out county-wide. So because of when we then opened it up, the numbers weren't quite what we were expecting, and where we rolled out some of it online, and that's where obviously majority of the providers were set up really to deliver it face-to-face in Redditch. So we did open it up then to some online, with WAC picking it up over the county. So I think that's why that offer's happened.
Yeah.
We've been funded now to roll it out into the county. So Sandcroft is one of them. So that's just how that's just happened. It was just because of the numbers that we were given didn't correlate. So it just opened up that.
Yeah, I know it started off with the numbers and then the numbers changed, but I was just wanting to point it out that
just to let you know, the Alliance, obviously we have been funded to
funding,
county. It's just that we just had to do the pilot first, because obviously the first non-NHS rollout from the VCS doing it, so we had to wait until we'd evaluated it afterwards and looked at it. But the plans are now in place for us now to come into Worcester again.
To reach out, and that was my point about there's been pots of funding given to specific projects like you just referred to, Lee. It's the bit about the core funding that's still under discussion.
Yeah.
The Alliance itself.
Okay, thank you very much.
Jonathan.
Sorry, I can't help just pick up this up, because Gaynor, you've made a very passionate and passion point, and you've been very persistent about this. I'm interested to know which organisations in Redditch then have benefited from this mental health pilot, because there's a lot of people who are experiencing homelessness, who are and some of that can be from pressures of life. So I'm wondering who's got it and how do they get it?
Are you talking about the funding for the organisations or the beneficiaries that can access it?
Yeah, I mean, ultimately it's about people getting the service, but it will be funneled through organisations. Which organisations got it, Lee? You're in that part of the world.
On this round, obviously this round, it's the Sandycroft, the Old Needleworks, Springfield Mind, Worcester Carers, and Onside got the administrative element of it for triaging with the mental health teams.
Broadly, what sort of number of, how much were we talking about here in terms of money? I have no idea.
Can I just say, I think we're going very specific here.
It's a bit specific here.
Okay, so can we move this conversation offline and actually?
I've got the information, Jonathan, so I can let you have it.
Yeah, if that's okay. Thanks very much. Sorry about that. It's just we're running over time on the meeting as a whole. So just like to say thank you very much, Pete. I think that was a very actually instructive discussion as well.
Great stuff.
Thank you very much. I think we'll move on back to the main agenda, if that's okay.